Okay, you know that feeling. That sudden, unmistakable gut punch. The cramping starts, the fever might follow, and you just know you're in for, well, a miserable time.
Hmm.
It's a classic stomach bug, a truly awful experience many of us have gone through or, worried about.
And you're right, that sort of cluster of symptoms can come from many things, but there's one bacterial culprit that is incredibly common, responsible for a huge number of those cases worldwide.
Which is exactly what we're zeroing in on today. We've been given access to a set of curated revision notes from one of our listeners, specifically focused on Campylobacter infection.
Ah, okay.
Yeah, the kind of information you might pull together when prepping for something like the MSRA exam. Our mission, to take those, dense notes and really unpack them, turn study points into a clear, high-yield guide that helps solidify this crucial knowledge.
Right, making it stick.
Exactly. It's about getting straight to the core understanding without wading through, well, textbooks.
Absolutely. And we're treating these notes as our primary source material for this deep dive, pulling out the most important nuggets to help you feel well informed on this specific condition.
All right, let's dive in and make this information stick. What exactly is this bug we're focusing on?
So at its core, we're talking about a bacterial infection. The key players here are usually species called Campylobacter jejuni and Campylobacter coli.
Okay, specific bacteria causing the trouble. And the material we're looking at emphasizes this isn't some, obscure issue, right?
Not at all. It's highlighted as one of the most common causes of bacterial gastroenteritis globally. And here in the UK, there's a significant public health angle. It's actually a notifiable disease.
Notifiable, right? That's a key term.
Yeah, it means doctors have to report cases. It's how public health bodies track its spread and, its incidence.
And that signals its importance beyond just an individual illness. So the defining symptoms we need to keep in mind.
Think of the classic gastroenteritis picture: diarrhea, often quite severe abdominal pain, and fever. Those are the main hallmarks. Okay. Though, as we'll see, the diarrhea can have a particular characteristic.
Got it. So we know what it is. Now, how does someone actually get infected? Where does Campylobacter come from, and how does it get into the body? Let's talk etiology and pathogenesis.
Well, the primary route is through contaminated food and water. Undercooked poultry is a classic source that comes up again and again in the notes.
Poultry. Definitely seems notorious for this one.
It is. Raw milk and contaminated water are also significant sources mentioned.
Okay.
But you can also pick it up directly from infected animals or their waste. This points to its nature as a zoonotic infection. It jumps from animals to humans.
Zoonotic, right. Animal connection is important there. What about from other people? Is that common?
Person-to-person spread can happen, yeah, typically linked to poor hygiene. But while outbreaks can occur maybe in places like nursing homes, most cases are actually described as sporadic,
Sporadic.
meaning they happen in individuals rather than big clusters, and are often traced back to consuming contaminated meat, particularly that poultry again.
So mostly from what you eat or drink or contact with animals. Person to person is less common, but possible.
That's the gist of it.
Maybe to help remember the main sources, we could group them, like
Yeah.
food, water, animals, and maybe people for that hygiene route.
Yeah, that's a solid way to organize the transmission routes in your head. Food, water, animals, people. Good one.
Okay, so who is most likely to actually get this infection? Are there specific risk factors that make someone more vulnerable?
Yes, several factors stand out in the notes. Obviously, consuming undercooked poultry or unpasteurized milk are high on the list.
Makes sense.
Drinking untreated or contaminated water is another major risk. Direct contact with farm animals or even pets can be a source, sort of circling back to that zoonotic link.
And travel. I saw that mentioned.
Absolutely. Traveling to areas with, let's say, less stringent sanitation. It's a known cause of travelers' diarrhea, particularly mentioned for places like Southeast Asia.
Right.
And as you'd probably expect, people with weakened immune systems are also at higher risk.
Okay, immune status is key.
And interestingly, certain jobs, like those involving close contact with poultry in processing plants, are mentioned as an occupational risk factor too.
Huh. So it's a mix of diet, environment, travel, your immune health, and even your job potentially. That's a pretty broad spectrum.
It is.
Thinking about this, maybe you could categorize the risks, like what you ingest: food, water, milk, who or you contact animals, people, your circumstances, travel, immune status. maybe like your work environment.
Yeah, breaking them down like that definitely makes the list feel less daunting. It covers all the bases mentioned.
Right, so once these bacteria are ingested, they find their way into the body. What actually happens on a cellular level to cause those terrible symptoms? Let's get into the pathophysiology.
Right. The process is quite specific according to the notes. The Campylobacter bacteria, once they're ingested, are able to invade the lining of the small intestine.
They don't just hang out, they actively invade. That's key.
Exactly. They get in, and once they've invaded, they start producing toxins.
Toxins again. It always seems to be toxins causing the misery with these kinds of bugs, doesn't it?
It often is. These toxins, along with the bacteria just being there, trigger an inflammatory response in the intestinal lining.
Oh, okay.
And it's this inflammation that directly results in those characteristic symptoms we talked about, the severe abdominal pain, the fever, and the diarrhea.
So it's the invasion plus the toxins causing inflammation that drives the whole clinical picture. Makes sense. The notes also mention that in rare cases, the bacteria can spread beyond the gut.
Yes, and that's where the potential for serious complications comes in, which is, a critical point we'll definitely revisit. It's important for revision.
Okay.
But the fundamental mechanism in the gut is ingest the bacteria, they invade the intestine, produce toxins, cause inflammation, leading to the symptoms.
That step-by-step ingest, invade, toxins, inflame, symptoms, that's actually a really helpful way to visualize it. Good memory tip.
Hope so.
So what does this look like from the patient's perspective, the actual clinical features? How does it present?
Well, the typical presentation has a pattern. After exposure, there's an incubation period. It can range pretty widely from 1 to 11 days according to the source material.
Wow, up to 11 days.
Yeah, but most commonly, symptoms appear within 2 to 5 days.
So you might have eaten something risky, say on a Sunday, and not feel sick until Wednesday or Thursday.
Precisely. And interestingly, sometimes people have what's called a prodromal illness.
Prodromal, like a warning.
Yeah, exactly. A sort of warning stage, maybe up to 24 hours before the main gut symptoms hit. This can feel like a general flu fever, headache, muscle aches.
Huh. A flu-like lead-in. Then the full force of the gut symptoms kicks in.
That's when the main event arrives. Severe abdominal pains and cramps, which can be really debilitating, and the diarrhea. The material highlights this can be profuse, watery, and quite characteristically, often bloody.
Bloody diarrhea. That seems really key for Campylobacter.
It's definitely a flag. Someone might have up to 10 stools a day. Nausea and vomiting are also common.
10 a day. Potentially bloody.
Mm.
Wow. What would you find if you examined someone suspected of having this?
On examination, the person would likely look unwell, maybe a bit pale. Their temperature could be elevated, although sometimes it can be low in very severe cases.
Okay.
And when you palpate their abdomen, there's often tenderness. It might be widespread or maybe focused in the lower abdomen, sometimes mentioned as the right or left iliac fossa specifically.
And with that much fluid loss, dehydration must be a major concern.
Absolutely critical. Assessing their hydration status is paramount. You'd be looking for signs like reduced urine output, a dry mouth, maybe dizziness when they stand up.
Okay, so key features to remember. Incubation period of a few days, maybe those flu-like symptoms up front, followed by intense abdominal pain, and crucially, often bloody diarrhea. Assessment for dehydration is vital.
Spot on. That combination, especially the bloody diarrhea within that 2 to 5 day window, is very suggestive.
Now, while that sounds pretty specific, lots of things can cause diarrhea and stomach pain. What else could present like this? What are the main differential diagnoses?
Right, yeah. Gastroenteritis is a broad umbrella term. The material we reviewed lists the main categories to consider. You've got your common viral causes like norovirus or rotavirus.
Ah, yes, the ones that sweep through offices and cruise ships. Very familiar.
Exactly those. Then you have other bacterial infections that can mimic Campylobacter. Things like Salmonella, Shigella, or certain types of pathogenic E. coli.
Okay, other bacteria.
And finally, you need to think about parasitic infections like Giardia or Cryptosporidium.
So viral, bacterial, parasitic, maybe VBP is a quick way to remember the broad groups.
VBP, yeah, that works. Viral, bacterial, parasitic. Helps keep them organized.
So how do we definitively nail it down and say, yes, this is Campylobacter and not one of the others?
Well, this is where the laboratory investigation is absolutely key. The definitive way to confirm Campylobacter is by sending a stool sample for testing. Specifically, a stool culture is what will identify the bacteria.
Right, the stool culture. Gold standard for diagnosis here. Okay, shifting gears slightly. How common is this, particularly in the UK? What does the epidemiology tell us?
We know it's a very common foodborne illness here. The notes state it causes thousands of cases every year in the UK.
Thousands. That's a pretty significant public health burden then.
It really is. And there's a specific time of year when cases are more frequent.
Oh, is there?
Yes, there is a notable peak during the summer months.
Summer? Huh. Any idea why?
Well, the notes don't specify exactly, but you could speculate it relates to things like warmer temperatures affecting food storage or handling, maybe more barbecues.
Right, undercooked barbecue chicken.
Could be. Or maybe increased outdoor activities involving potential animal contact, like farms or petting zoos.
Summer campy, maybe that helps remember the seasonality and the link to outdoors animals.
Summer campy. I like it. Does it affect all age groups equally?
That's a good question.
While it affects everyone, the data mentioned shows an interesting trend in the UK. The incidence has actually been increasing in older populations.
Really? Older people?
Yeah, while decreasing in infants and young children.
That's quite counterintuitive. You often think of young kids being highly susceptible to gut bugs.
It is a bit surprising. The reasons aren't entirely clear from the notes, but it's an interesting epidemiological shift to be aware of. So, yeah, common, thousands of cases, peaks in summer, and that shift towards older age groups.
Okay, that gives us a good picture of its footprint in the population. Stepping back to diagnosis then, we know a stool sample is key. When exactly is it recommended to send one, according to these notes, and what information is needed with it? Let's nail down the investigations.
Okay, so a stool sample is recommended whenever you really need that microbiological diagnosis, particularly if the symptoms are severe or notable, like we said, having blood in the stool.
Blood is a big trigger for testing them.
Definitely. It's also important if the person has been in hospital recently or taken antibiotics recently, or if there's a potential public health concern.
Public health risk. Like if the person is a food handler.
Exactly that. Or if the person is known to be immunocompromised or has a history of recent travel, especially to those higher risk areas.
Right.
These are all situations where identifying the specific bug becomes much more crucial for management or public health tracking.
Okay, so just to recap the triggers for testing. Blood in stool, recent hospital stay or antibiotics, high-risk job like food handler, immunocompromised status, or recent travel. That's a good checklist. What info needs to go with the sample to the lab?
The notes are quite specific here. You need to include the date and time the sample was collected, the person's immune status, any recent travel history, and crucially, details about potential exposures like contact with animals, any suspicious food they ate, or water sources.
That context sounds vital for, potentially tracking the source if it's part of an outbreak.
Absolutely. And we touched on it being notifiable earlier. What does that mean in practice regarding investigations?
Good point.
It means that for confirmed cases of food poisoning like Campylobacter, the diagnosing doctor or lab needs to notify the local public health team. They use this information to look for potential outbreaks or common sources, like a bad batch of chicken at a supermarket, for example.
Right, connecting the dots for public safety. And in those really severe cases with lots of diarrhea and the risk of dehydration, any other tests needed?
Yes, for severe presentations, monitoring the person's kidney function and electrolyte balance is really important. So blood tests like urea and electrolytes, UNEs, and creatinine are needed to assess and manage dehydration.
Okay, so stool culture is the go-to diagnostic. Send it with detailed info, certain risk factors or symptoms are present. Notify public health if it's confirmed food poisoning, and remember to check bloods like UNEs in severe cases.
Got it.
That covers the key investigation points.
How do we actually treat this once we know or maybe strongly suspect someone has it? What's the management strategy?
Well, the most important principle, and this comes across clearly for most people with Campylobacter, is supportive care and staying well hydrated. So fluids are key.
Absolutely. Thankfully, the majority of cases resolve on their own, usually within about a week, without needing any specific treatment beyond that.
So for many, it's just fluids and rest. Ride it out.
Pretty much, yes. Antibiotics are generally not given to everyone. They're really reserved for more severe or prolonged infections, or specifically for individuals who are immunocompromised.
Okay, so not routine antibiotics. But if they are needed, which ones are the first choice according to these notes?
The material indicates that clarithromycin is the preferred first-line antibiotic.
Clarithromycin, okay.
Ciprofloxacin is listed as an alternative, but there's a specific caution mentioned about its use due to increasing bacterial resistance to it.
Ah, resistance, always a factor with antibiotics. So clarithromycin first, Cipro maybe second line, but be aware of resistance.
Got it.
Rehydration is crucial.
Yeah.
What about medication to, stop the diarrhea itself, like loperamide?
Yeah, antimotility drugs like loperamide, they are mentioned, but typically only considered in specific situations, and the advice is to use them with caution.
Why the caution?
Well, the concern with using them in some bacterial infections is that it might potentially prolong the illness or, in some cases, even worsen outcomes by keeping the bacteria or toxins in the gut longer.
Okay, so not a straightforward stop the diarrhea approach. Focus on hydration, use antibiotics sparingly only for severe or immunocompromised cases, and be careful with anti-diarrhea meds. That makes sense.
Exactly.
Beyond treating the individual, stopping the spread seems huge because it's so common. What are the key prevention points, especially for managing an infected person, to stop them giving it to others?
Yeah, public health measures are critical here. A key rule highlighted is exclusion from work or school. The specified duration is 48 hours after the last episode of diarrhea or vomiting.
That 48-hour rule after symptoms stop, that's a really clear, practical guideline, easy to remember and important.
It is. Other important measures involve pretty standard but essential hygiene. Rigorous hand washing, especially after using the toilet and before handling food. Avoiding sharing personal items like towels. Ensuring laundry, especially soiled items, is washed properly at a hot temperature. And cleaning and disinfecting surfaces regularly, particularly in bathrooms and kitchens.
Good hygiene basics, but ramped up.
Definitely. The notes also add an interesting point that giving antibiotics might reduce how long a person excretes the bacteria in their stool, which could potentially reduce the period they can spread it.
Oh, okay.
Although the main reason for giving antibiotics is still primarily to treat the severe illness itself, not just for public health reasons.
Right. So just to summarize management, hydration and supportive care are the absolute backbone. Antibiotics are for specific cases severe, prolonged, immunocompromised. Be cautious with loperamide. And strict hygiene with that 48-hour exclusion rule is key to preventing spread.
That really captures the main management points derived from the sources, yes.
Okay. So what's the typical outcome then? Do people usually recover fully? And crucially, for revision, what are the potential complications we need to be aware of? Let's talk prognosis and complications.
Generally, the prognosis is good. Most people do recover completely, usually within about a week, without any lasting issues.
That's reassuring for most cases.
It is. However, for severe cases or in people with weakened immune systems, there's definitely a higher risk of complications developing.
And these complications, I suspect, are often the high yield points for exams, aren't they? Some sound quite surprising based on the notes.
They really are. A major one that's highlighted is Guillain-Barré syndrome, or GBS.
GBS from a stomach bug.
Yes. It's an autoimmune disorder where the body's immune system mistakenly attacks its own peripheral nerves. This can lead to muscle weakness, tingling, and potentially even paralysis. And Campylobacter infection is actually one of the most common known triggers for GBS.
Wow. A gut infection potentially leading to paralysis. That is a really striking link and definitely one to remember for exams and just generally.
Absolutely. It's probably the most significant post-infectious complication mentioned. Another important one is reactive arthritis.
Reactive arthritis.
Yeah, this involves inflammation in the joints, often affecting the knees, ankles, or feet that develops after the initial infection has cleared up. It's the body reacting to the previous infection.
Okay, so GBS affecting the nerves and reactive arthritis affecting the joints. Those are two big non-gut complications to keep firmly in mind. What else is on the list of potential problems?
Well, there are rare but very serious complications like sepsis, that's a life-threatening systemic response to the infection spreading,
Right.
and toxic megacolon, which is a dangerous swelling and distension of the large intestine.
Nasty stuff indeed.
Very. And then, of course, there are the more direct consequences of severe gastroenteritis itself. Significant dehydration and electrolyte imbalances, especially if fluids aren't replaced adequately.
Makes sense.
Other potential longer-term issues mentioned include developing post-infectious IBS irritable bowel syndrome, meaning persistent gut symptoms like pain or altered bowel habits even after the bacteria are gone.
Ah, so it can have lingering gut effects too.
It seems so. And finally, it can potentially interfere with the absorption of medications someone might be taking for other chronic conditions just due to the gut disruption.
Okay, that's quite a list. So while most people recover fine, there's a definite important list of potential follow-on problems. GBS and reactive arthritis seem like the really key extraintestinal ones to commit to memory.
Definitely focus on those post-infection extraintestinal effects like GBS and reactive arthritis. They're often tested.
Good tip.
Yeah.
Finally then, pulling everything together, how can we avoid getting this unpleasant infection in the first place? Let's wrap up with prevention.
Yeah, prevention really circles back to understanding where the bug comes from and how it spreads. It involves measures all the way across the food chain, right down to individual kitchen hygiene.
So things like cooking food properly must be top of the list.
Absolutely essential. Thoroughly cooking meat, especially poultry, is paramount. The notes stress this. Also, avoiding cross-contamination.
How so?
By keeping raw and cooked meats completely separate, using different chopping boards, different utensils, and rigorously washing hands and surfaces immediately after handling raw meat.
Standard but absolutely vital food safety rules then?
Exactly, they're standard for a reason. Also, ensuring milk is pasteurized and water is properly treated.
Right.
And related to that, avoiding untreated tap water or ice, particularly when traveling to areas where water sanitation might be a concern.
Back to the travel risks we mentioned earlier.
Makes sense.
Yes. And it's crucial, as we touched on in management, that individuals who are actually infected don't handle food for others until they're clear.
Okay.
Using separate cutting boards for raw meats versus ready-to-eat foods like salads is another good practical tip mentioned.
Sure.
And just general proper hand washing applies to everyone all the time, especially after using the bathroom or before eating.
Seems obvious, but always worth repeating.
It really is. And one final point from the notes specific to healthcare. Infected healthcare workers absolutely should not be working to prevent spreading it to vulnerable patients.
Okay, so preventing Campylobacter boils down primarily to really diligent food safety practices, especially with poultry, and avoiding that cross-contamination coupled with good general hygiene and being mindful of water sources, particularly when traveling.
Those are definitely the key takeaway prevention strategies summarized from the material we looked at.
Wow. Okay, we've really navigated through the essentials of Campylobacter infection, haven't we? Taking those listener revision notes and structuring them into what hopefully feels like a clear, high-yield guide, from understanding what it is, where it comes from,
Right.
through the symptoms, those tricky complications, right down to how to avoid it.
Yeah, and understanding these specific points is undeniably crucial. Whether you're consolidating knowledge for an exam like the MSRA or simply aiming to be better informed about common illnesses that affect us all, we really hope this deep dive has made this information much more accessible and memorable.
We certainly hope so. And thank you, listener, for sharing your sources and letting us build this deep dive around your material. It's actually fascinating to see how specific preparation notes can guide a broader understanding for everyone.
Mm-hmm.
Now, thinking about just how widespread Campylobacter is, and then wrapping your head around that connection to something as potentially severe as Guillain-Barré syndrome, does that fundamental link maybe change how you might approach something as routine as handling chicken in your own kitchen, or perhaps make you think twice about drinking tap water somewhere new when traveling?
It definitely adds a different layer of significance to everyday actions, doesn't it? And considering its status as a notifiable disease here in the UK, with, as we said, thousands of cases reported each year, what does that tell us about the wider public health ecosystem and maybe the importance of tracking even these seemingly common infections?
It's something to definitely ponder on. And for those of you out there maybe focused on exams like the MSRA, remember that understanding the why and the connections between these facts, like how a common gut bug can potentially cause neurological issues, is often what helps the information truly stick.
Yeah.
It's key to applying your knowledge effectively.
Absolutely. And if you are looking for additional resources to support your revision journey for the MSRA, you might find helpful materials over on passthemsra.com and also freemsra.com. They're built to complement focused study like this.
Great suggestions. Thanks for joining us for this deep dive.